Well, good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. In this particular video, I'm going to start off with a case study, and that will act as a segue into a broader conversation / discussion of the case study. You are a paramedic on an ALS crew. You get called to the scene of a 30-year-old female patient who complains of acute onset pleuritic chest pain. She points to where she feels the pain. She has some dyspnea, and she has increased pain on inspiration. Her vital signs are roughly unremarkable, with the exception of a slightly elevated heart rate around 100 or so, and her oxygen saturations are reading in the mid to upper 90s on low flow supplemental oxygen. All right. She doesn't have a whole lot of substantial history that you can get. She's on oral hormonal contraceptives. And you go ahead and in due diligence, you go ahead and obtain a 12-lead ECG. And this is the ECG you get. You do note that there are some ST changes. You've got some inverted T waves in the inferior leads, as well as some T-wave inversion in the V1 through V4 leads, or those high right precordial leads. Other than that, you see some very non-specific ST changes and an elevated heart rate of around 100. All right, so now the question is, how do you manage this patient? What are your concerns? What sorts of differentials are you thinking about? And how are you going to communicate that to the receiving facility? So just take a second to stop the video, think about what's going on for a little bit, and then go ahead and hit play again. All right, so let's talk about this situation. So this is an important concept that I want to emphasize when it comes to ECG interpretation, particularly when it comes to paramedics, EMS providers in general, and 12-lead ECG interpretation. The main thrust of education really does surround using the 12-lead to identify the classic indications of ischemia, injury, and infarction. And then that drives us to make decisions about code heart or cath lab activation in integrated healthcare systems that have those sorts of things set, which I would say most moderate to large size cities are going to have some sort of integrated cardiovascular interventional system that's going to integrated and will include EMS and the ability to provide some sort of field activation. The question being, do the findings with this patient, the history, physical exam, and the limited diagnostics available, is this enough information for us to call a code heart and activate the cath lab? Maybe, maybe not. It certainly does not meet the standard criteria that people use, the so-called STEMI criteria, which I have talked about the limitations of using STEMI as the sole criterion for activating the cath lab. And of course, I'm a big proponent of the occlusion myocardial infarction, or OMI versus NOMI paradigm, where in about a little less than a third of patients who fall into the in-STEMI category are actually experiencing a substantial occlusion that is resulting in injury and infarction to the myocardium, and therefore really do need to be treated like STEMI patients, and hence the term OMI or STEMI equivalent, depending on the organization and the paradigm that they're using to conceptualize this. The question is, does what we see with this particular patient even really meet OMI criteria? Is this something that could be considered an OMI? Well, you've got some ST depression in the precordial leads V1 through V4. I think you certainly are well validated in doing a right-sided ECG, getting posterior leads, looking for the presence of right ventricular infarction with V4R, and looking at the posterior leads to see if you have any elevation, and are those inverted T waves actually suggesting that you have posterior wall infarction. I would say that the morphology of the depression is not the common morphology of ST depression that you would see in posterior MI, where it tends to produce a horizontal ST depression. But I think you're well justified, and I would recommend strongly in getting posterior leads in this patient. So let's say we do that, and the posterior leads do not show ST elevation that meets any sort of criteria for posterior wall MI. Now, where does that put us? Well, that puts us in a situation where we have to, and we should always do this, we should always think about the differentials for ST segment changes, right? Not all ST segment changes are going to be the result of ischemia, injury, and or infarction. And there is a very large list of differentials that we need to think about in our patients, right? Such as head injury, right? Such as head injury, such as certain cardiomyopathies, such as a long list of channelopathies like Brugada syndrome that will present with abnormal ST segments, right? We will also want to think about things like pulmonary embolism, right? So there are electrolyte imbalances, hyperkalemia, for example. It can certainly cause changes, bundle branch blocks, so on and so forth, right? So there are a lot of things that you need to consider, and I would suggest that this is something that you do the 12 lead and you transport the patient and do whatever you do, but I think there's some really important considerations here. And one of the important considerations is that the differential diagnosis of a pulmonary embolism, or a PE. So electrocardiographic changes there are some classic quote unquote textbook changes that are talked about on the ECG. These are not very common, however. So the absence of these changes cannot be used to exclude the differential diagnosis of a pulmonary embolism. So let me just talk about some of these. The most common things that you're going to see in the setting of a PE are going to be very non-specific ST changes, right? About half the time you're going to see that. Just underneath that, you're going to see sinus tachycardia. Sinus tachycardia is present in about 40 to 50% of all people that present with pulmonary emboli or a pulmonary embolism. Right ventricular strain patterns are relatively common. Just a little over a third of the time you're going to see this. And right ventricular strain tends to manifest with T-wave inversion in those right precordial leads that kind of are geared more toward the right side of the heart, V1 through V4 specifically, right? And in addition to that, you're also frequently going to have T-wave inversion in the inferior leads, all right? So where you have that, you need to be thinking about the differential of a pulmonary embolism. And of course, an increase in the amplitude of the R wave in V1, about 9% of the time. And then the classic textbook pattern, the pronounced S wave, large S wave in lead 1, large Q wave or pathological Q wave in lead 3, and an inverted T wave in lead 3. This is the S1, Q3, T3 you see that pattern only about 20% of the time. So only about 1 in 5 PE are going to present with that pattern. So the absence of these patterns cannot be used to rule out the possibility of a pulmonary embolism, but the presence of these patterns with concerning history and physical exam findings should make you highly suspicious of the possibility of a pulmonary embolism. So if we take another look at this ECG, you do see the T-wave inversion in V1 through V4, and you also see ST segment depression, T-wave inversion in the inferior leads. Now, you might think that that could be global ischemia, but taking the history into context, this is a sudden onset, this is pleuritic chest pain. Pleuritic chest pain, particularly when a patient can pinpoint it with these non-specific ST changes, should be a big red flag for the possibility of a pulmonary embolism. Pleuritic chest pain is often associated with some degree of lung irritation and or infarction, and we know that this is the common pathogenesis that we can see in pulmonary emboli, particularly larger PEs that can be problematic, right? So anytime you have these non-specific findings with concerning history and physical exam, right, in this case is a 30-year-old female, right, she's on oral hormonal contraception, we know that that can increase, right, that can cause some coagulopathies, increase the risk of clot development, DVTs, which can increase the risk of PE, right? Among other kinds of history that could be potentially concerning. In this case, we see ECG findings suggestive of a right ventricular strain pattern, mainly the inverted T waves in V1 through V4, as well as some T wave inversion in the inferior leads, which are more right-sided. So we should be highly suspicious of the possibility of a pulmonary embolism, and you want to be able to articulate your concerns to that receiving facility, preferably that receiving physician, right? ER physicians may or may not be highly or well-versed in looking at these more subtle ECG findings. And again, the primary thrust of what happens in the initial patient workup in the emergency room is really, is this a STEMI or an NSTEMI or not, right? And so it's very easy to look at this, particularly when you're busy. Oh, it's a young person with chest pain, some non-specific findings. Okay, it's not a STEMI. Let's get some cardiac enzymes and get some coags and do repeat or serial ECGs, and maybe not ever consider the possibility of something like a pulmonary embolism. And that could potentially lead to deadly complications. So we need to be able to articulate our concerns to that receiving facility, plant that seed in that clinician's head, and then that can help them hopefully think about doing additional workups on that patient and possibly identifying the presence of a pulmonary embolism. I wanted to bring this up just because I've seen several discussions about PE, and then I watched a couple of or listened rather to a couple of episodes of the IMCRIT podcast, where I believe it's about a month ago, they talked about a young, I believe is a young male patient that presented with similar ECG findings. This was not an EMS presentation, but it was a young gentleman that presented to the emergency room having some pleuritic chest pain, had some non-specific ST changes, and ended up getting discharged from the emergency room. They did not initially consider the possibility of a pulmonary embolism. And over the course of the next couple of weeks, this young guy continued to have chest discomfort. At one point, he called EMS. EMS essentially begged him to go to the hospital. He, refused. I think some of that was because he was told by the hospital and by primary care that, he wasn't in any immediate danger. And so, I can see him kind of, well, I don't really want to spend the money if this really is an emergency, because I've been told this by physicians. And he ended up dying approximately, I think it was about 2 weeks after the initial presentation of I don't know if it was a massive or a submassive pulmonary embolism. And there was a lawsuit involving the ER physician. The ER physician ultimately lost, and a pretty substantial judgment was made against that physician. And I believe the case is currently going through the appeals process. And perhaps had that ER physician had a little more context and was able to critically think beyond just STEMI, NSTEMI, at this point, I really think that teaching STEMI, NSTEMI is inherently harmful. I do know the arguments for it, that it's easy, it's low-hanging fruit, it works. But if that's the main thrust of what you learn, what you teach, what you're thinking about, it's very easy for these other things that are potentially just as devastating as a myocardial infarction of slipping through the cracks. And I think at this point we really do need to broaden things out. And I think that ER physicians really should be able to look at an ECG like this and go, wow, that's not normal. It's not a STEMI, or it's not an OMI if you're a little more progressive, but what are the differentials for these types of ST changes? I need to be thinking about them, and then I need to be addressing them. And this is why I am such a big advocate for differential diagnoses in documentation. This is one of the things we actually do at our paramedic program. Is our paramedic students, when they document their patient contacts, they have to, at a minimum, articulate 3 differential diagnoses, and they have to put a probability, like how confident am I in this, and then they have to explain why they chose that differential, because I think it is so important for that critical thinking. And even though we may not be able to do much about a pulmonary embolism definitively, being able to articulate our concerns and demonstrate that we have a mastery of ECG interpretation, and we can present a well thought out, articulated argument to that receiving physician or provider, that may be enough to prompt them to think about this and go, oh, you know what? Maybe I need to look at this, and maybe I need to consider some other possibilities, do a better workup, and then perhaps some of these individuals' cases won't fall through the cracks. All right, so hopefully you all enjoyed this particular video, and we'll see you in the next one.